Hey, welcome to the Healthful Woman podcast, the fastest growing podcast in women's health. Today's Monday, September 1st, 2025, Labor Day, in honor of a day devoted to labor. On today's podcast, Melka and I talk about elective induction of labor. It's a topic that comes up a lot in obstetrics and has taken some fascinating twists and turns over the years. All right, in terms of the upcoming schedule for the end of summer and the fall, we have a bunch of mailbag podcasts, so do keep sending in those amazing questions. We're also going to be dropping our annual Fasting in Pregnancy podcast with Melka the week of Yom Kippur, so stay tuned for that. Finally, after redropping the podcast last week on cancer genetics, I realized it's probably time to revisit a lot of our podcasts on breast cancer, screening, diagnosis, management. So we will likely do that in October, which is Breast Cancer Awareness Month. I'm also happy to announce that I have the honor of joining the board of directors of Sharsheret, which is a fantastic organization devoted to supporting women and families with breast and ovarian cancer. We're going to be discussing this more, but if you'd like more information on Sharsheret, you can check out their website, www.sharsheret.org. That's SHARSHERET. All right. Thanks for listening. Enjoy your Labor Day. See y'all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Melka, welcome back. How you doing? This is like the spring of Melka. We got you for a bunch this time after a long hiatus.
I'm so excited.
So we're talking today specifically about elective induction of labor. And just as a plug for our listeners, if you want some background to this, I would recommend two podcasts we did. The first was with Dr. Costant in March 8th, 2021.
Oh, throwback.
Yeah, which was Induction of Labor, Everything You Need to Know. Apparently not everything, because we're covering some more. And then the second one was more recent in March 17th of 2025 with Dr. Nassim, Induction of Labor and the ARRIVE trial.
Ooh.
So I think those two podcasts together lead to this podcast, which is the concept of an elective induction of labor. And we're going to talk about that. So, Melka,
Yes.
if you could honor us with what is an elective induction of labor?
So it's inducing labor. So starting labor sort of by choice without a strong medical reason or strong medical indication.
Right. So,
And again, it's very vague, but I sort of look at it as a lot of the things that are not like diabetes, high blood pressure, your water broke, like where you don't have that like strict medical indication.
Right. And so when we have an induction of labor where there is one of those indications and there's a whole list of them, we sort of call that an indicated, like because there's an indication, an indicated induction of labor or just an induction. And then for the people who don't fall into one of those categories, we call it elective. Now, I'm curious, what do you think about the term elective?
I don't love it.
Why not?
Because I feel like nobody is really just out of nowhere, just, hey, let me be induced. Like there's usually something that's making them say, I want to be induced or I think I should deliver by a certain time.
Yeah, I think elective does have a little bit of pejorative connotation to it, maybe a little shame involved, that it's, whimsical or some, like, oh yeah, hey,
And I think it's why we're not talking about elective C-section anymore. I think nowadays, the correct terminology is C-section by maternal request.
Right. So, which may just be a euphemism, but I think, there, and again, since prior to the ARRIVE trial, there was some negative connotation to saying elective induction because, again, for review, for those who did not just listen to me and did not listen to the ARRIVE trial induction podcast as a primer, prior to that trial, we really felt, certainly someone with their first baby, that if you induced their labor, there's really a downside of increasing their risk of a C-section.
Yes.
And so it really was much more frowned upon medically
Mm-hmm.
to induce people electively. And I think that's where sort of that term came in. Like, I'm electing to do it. I
Right.
get that there's some downside to it. I may end up with a C-section, but I'm choosing that for reasons A, B, C, D, whatever it is. We'll
Mhm.
talk about the reasons, but okay. As opposed to I'm choosing it because there's a risk, right? So I'm just choosing it. Fine. But since the ARRIVE trial, where we've learned that really that's not true. If you induce labor and you do correctly in your patient, you're not increasing the risk of C-section. People sort of started coming up with a term like risk reduction, like
Yeah.
induction for, reducing your risk. Meaning, because there is some risk to staying pregnant. It's not great, but there's a little bit of risk. So the thought is, I'm not just being induced for the hell of it, but I'm inducing at 39 weeks because I don't want anything bad to happen, let's say in the next week or two, which makes it a little bit less judgy in that sense. But it's really true. And it actually, it turbo boosted this conversation, which did happen from time to time, obviously. Before the ARRIVE trial, people would ask about being induced, and we talk about this, risk, benefits, blah, blah, blah. But now it's really different because the whole discussion about the downside of induction has shifted.
Yeah.
In that sense. So knowing that, are you asked about this a lot?
Yes.
Okay. Who's typically asking these questions? They're just saying, hey, I'd like to be induced, or is it, I've heard that it's okay?
Both. Not so much I've heard it's okay, but I've heard that I should be doing this. So some of it is my friend, sister, whoever delivered at 39 weeks and they said I should do it.
Right.
Some of it is the social media stuff,
Right.
Which is, quote, nothing bad happens after 39 weeks.
Right.
So you should deliver exactly at 39 weeks.
Right.
And a lot of that sort of encouragement.
Right.
To deliver at 39 weeks or as close to that as possible.
Right. Those kids with their social media.
See, that's why you bring me on here. I'm young. I give you that perspective.
Yeah. You give me the social media perspective. No,
it is. I had a patient show me an Instagram video of somebody with millions of followers talking about how everyone should be induced at 39 weeks.
And it's interesting because there are some people medically, whether it's obstetricians, whether it's maternal fetal medicine specialists, whoever is, who are also saying you should be induced. Not just that you can be induced, but you should be induced at 39 weeks. And again, their thought process is purely mathematical, that if you get induced at 39 weeks, there's no medical downside because you're not increasing the risk of a C-section. And there is some medical upside, lower risk of hypertension. And then obviously you're probably lowering the risk of stillbirth to the baby, but you're taking it from a very, very, very low risk, obviously, and just making it a little bit lower. And so they're saying, well, if you just put those on a scale, the path of least risk is to be induced. And I don't disagree with the mathematics of that, but the problem is it is a little bit more complicated because inductional labor is a very different process for people than going into labor on your own or waiting to go into labor on your own. And some people are going to want to be delivered as soon as possible, and other people don't. Other people, for whatever reason. So knowing that it is a discussion. There's some disagreement about this medically. There's some disagreement about this sort of in the lay press, as you said. People have different opinions about it. So let's talk about the reality. So for someone sitting on the patient side, she's pregnant, she's 36, 37, 38, she's coming up on 39 weeks. And she brings up the conversation with you, hey, what should I be doing? Should I be getting induced at 39 weeks? Should I be waiting until when? How do you have that conversation? And we'll talk about sort of the pros and the cons of each of the options.
So I always start by asking them what their thoughts are. Do they have a specific feeling one way or another? And again, very rarely do I find an individual patient just saying, I want to be delivered just by choice.
Right.
There's usually something driving it, that doesn't have a specific diagnosis. Sometimes it's sort of what we call social reasons, where she says, well, I'm moving in 2 months. And if I deliver at this time, it makes it a little bit easier. 2 months from now, sometimes it's, I'm getting uncomfortable. I'm not in severe pain where I can't move, but third trimester is miserable. It's hard to move around. I'm just ready to be done.
Right.
Some of it is coordinating with family. I have family out of town. They want to come in. I just want to have a date that I could put on the calendar.
Right.
And then some of the little more of the medical things of, the pain, some women get incontinence in the third trimester, and they're just, for a variety of reasons, like physically over it.
Yeah. I find some people also, like you said, socially, they're thinking, I'm Jewish, it's going to be a boy. I have a bris. I got a bris coming, and I want it to be a certain day. I don't want it to be a certain day. I want it to fall on a certain holiday. I don't want it to fall on a certain holiday. And these are, they're not medical reasons, but they're not inconsequential to people. And some of it's sometimes just anxiety.
Yeah.
Like I'm just worried. Like if the baby's fine now, I don't want to wait until something happens, let's say. Or sometimes people, it's some level of control for them. I don't want to just wake up at 3 a.m. in labor. I still want to have a date on my calendar. I'm coming in this day. I'm going to get induced, and this. That doesn't always work, obviously, because but whatever. For some people, they feel that having that, like, this is the end line for me. It's not going past then. I sort of can work my life around that. Gives people some comfort.
Yeah, people see relatives with preeclampsia. And they say, well, I know I am at low risk for it, but I just want to be able to deliver early before that happens to me.
Right.
Another one I see a lot is concerns over the baby's size.
Right.
Where it's not necessarily a very big baby where we're recommending induction, but a baby that's above average. And it sounds scary to a woman to hear like, oh, you have an 8-pound baby. Oh, now I have to deliver that?
Right.
Well, what if I don't go at 39? What if it's another week or two and the baby gains another ½ pound? Like I just want to, get it out as early as possible.
Right. What are reasons someone wouldn't want to be induced at 39 weeks? Like, let's say it was the opposite. They're at a practice and their doctor midwife says, hey, we normally induce at 39, or we always talk to people about inducing at 39 weeks. What are the types of things that would lead someone to not want that to be done?
It's medicalizing what is often a natural process. Some people feel their body's not ready, that they're young, healthy, they can wait longer. Why go through the process of an induction?
Right.
Where you're in bed, you're getting medications, you're not at home, you're not moving around. Like, why do that unless it's strictly necessary?
Yeah, I think that's the big one for people. And,
some people see it as tempting fate, where they're like, it's just like, it's weird to me to be planning a delivery when the baby's not ready, or my body's not ready, or I'm not in labor on my own, or I don't have something else medical going on.
Yeah. So much of this is personality and sort of how people view medicine and, all these things. And it's all good, as they say. But I definitely agree that there's some people who are like, on the first end, more logistically, they're like, listen, I'm looking for a labor where trying to labor at home for a significant amount of time. My doula is going to come to the house. We're going to do a few things. And then if A, B, and C will come to the hospital, but I'm really looking to be more mobile, and I'm trying not to have an epidural, let's say, or, this is how my vision of how my labor and birth should be. And if you induce me, it's not going to be like that. Yeah. It's going to be different. It may end the same way, but
it's possible. It's certainly possible. We've had inductions that last a long time and people go through it without an epidural. But I think it's harder for patients.
And it's just different. It's sort of not what they envision. And like, listen, I want it to be a certain way, not in a selfish way. This is how I sort of, my ideal way of how I want to labor and have this baby be born is a certain way. And you're telling me another way, and it's not definitively better. So I'm not going to choose it. I'm going to choose I'm going to stick with my plan. Yeah. That's one thing. And the other thing, I agree. There's definitely people who are they're just weirded out by like interfering with nature, and they're like, and I get it. And they'll be like,
and it's not an unreasonable thing.
No,
like if there's 100%. A medical thing or the water breaks, like it's not people are unreasonable. They just literally, people say it feels like it's tempting fate.
Yeah. They're like, I don't want to, if you tell me I need to do it, I'll do it, and then, but otherwise I'm just going to let nature take its course, as they say. And again, I think that all of these opinions are reasonable, which is part of the reason I've always pushed back against the doctors who have said, based on the ARRIVE trial, hey, we really should, looking at the math, we really should be recommending induction to everybody. Yeah. And like I said, I don't disagree with the math. Like I get it. But, labor is a very personal, it's a very monumental event for people. And I think that, part of our job is not just to say, well, looking at all things, this one gives you a risk of 1 in 1,000 and this one gives you a risk of 1 in 2,000. So you should pick the 1 in 2,000 and that's a medical recommendation. Like, all right, you have to sort of look at bigger picture and, 999 out of 1,000 times plus, it won't matter which one you choose. So how critical is it if that's what we're talking about? And so for me, I usually tell people, I think 39 weeks is very reasonable for someone who wants that. Again, for all the reasons we said before that they want it. And I think for people who don't, I think it's very reasonable to wait. Again, until there's a reason you need to, and what that is depends on the person and this or that and everything in between. And so I usually start like, what do you want? And it's kind of like, do you want to be delivered as soon as possible? Do you want to wait as long as possible? You sort of like, well, let's cut the difference, and let's deliver after. And a lot of people are like, they're like, well, I don't really want this. I don't really want that. What's the middle option? What's baby bear? And I'm like, well, 40 plus weeks. I'm like, okay, that sounds good. And they're all, one is just as good as the other. And so much of it, I think it's important. This is really where that magical shared decision-making thing that no one quite understands comes into play, where you really are deciding this. Like, I'm saying medically whether I think one is much better than the other.
Yeah.
And you're telling me, you the patient are telling me which one is more important to you, which one is more meaningful to you, which one do you want? And then we can come to a decision that's right. And it's a big thing. So if someone is, let's say, planning to get induced at 39 weeks. So we discussed sort of the upside to that. And we discussed, well, I guess we didn't really, what is the downside to being induced?
The biggest downside I see is that the induction doesn't work and you end up with a C-section.
Okay.
In our practice, our hospital, we're admitting people for delivery. There are hospitals out there where people may admit for induction, give some medication, nothing happens, the patient goes home and they come back. Like, I've heard of that, but that's not what we do in our practice. Like, typically we're admitting you for delivery. So sometimes the induction just doesn't work. You have all the medications all the time, we wait, it doesn't work, you end up with a C-section. It's not the end of the world. It's still, healthy mom, healthy baby, but that may not be the ideal outcome for somebody.
Right.
With the longer labors, you also start seeing higher rate of things like infection, higher rate of bleeding after delivery. I think some of those longer labors have a little bit of a harder recovery too.
Yeah.
Somebody that's in bed for 27 hours, when they first get out of bed, they're going to feel a bit more uncomfortable than somebody who had labored at home and it was a little bit faster. And, again, I don't think these are very extended recoveries.
Yeah.
But I think you see it in the first few days.
Yeah. And I think that, even if, let's say, the statistical likelihood of a C-section is the same. Right? Which it is, whether you induce or whether you go home and wait. I do think that for some people, if they chose an induction and it ultimately ends up in a C-section, they feel differently about it than if they went into labor on their own and ended up with a C-section.
Absolutely. And when I talk to patients about this, I'll tell them, like, we know that this doesn't, as best as we know, this doesn't increase your risk of a C-section. This is not guaranteeing a vaginal delivery.
You have a risk of C-section no matter what we do.
And some people hear that and they're like, I don't care. Whatever it is, I don't care. Let's just do it. I'm done. And then there are others that hear that and that is very devastating to them. Where they say, if that's what it is, that's what it is. But months from now, if I look back and I had a C-section because I chose to be induced, I'm always going to wonder what would have happened if I waited. Of course I could have waited. I could have had a worse outcome. I could have still had a C-section, but maybe it would have been different.
It's sort of that, those feelings of guilt. Again, they're not necessary feelings of guilt, but that's natural. People sometimes just regret a decision if it didn't end the way they wanted it to. We see that all the time in people with medically indicated inductions that still end in a C-section. That they still feel unhappy about it. And again, like, you sort of not that you should be taking the blame, but I think people do look back on it differently. Yeah, and I think that's not to be minimized. And I sometimes, when I'm discussing this or decisions like that with people, I'll say, all right, most of the time it's going to go well, and some of the times it's not. It doesn't mean something horrible is going to happen, but just not the way you expected it. Are you the type of person who would feel really, really guilty about that for the rest of your life? Or are you the type of person who'll be like, yeah, whatever, these things happen. And if it's the first one, you really have to consider your decision strongly. Maybe you don't want to be in that position, to set yourself up for that. Whereas the other, maybe you do. And that's why this is such a more like a deeper conversation than just the numbers. There's so much like psychology that goes into this also. And I think that's important.
Oh, one more thing in terms of the downsides.
Yeah.
It can't always be easily scheduled with hospitals. I don't know if we're going to get into that.
Yeah, we're going to get into that, the logistics. Listen, I think if I had to summarize it, it's reasonable to deliver 39 weeks. It's reasonable to wait. The main advantage to 39 weeks sort of is if you want it for A, B, C, D, there's a slightly lower risk of getting high blood pressure, maybe slightly high, low risk of other, bad things happening. And the main downside of delivering 39 weeks by induction is you're definitely getting induced. It's going to be a long labor, right? When you get induced, it's longer than if you went into labor on your own. So the experience is different, which usually means you have a higher chance of getting an epidural. Like you said, not definite. You can do without one, but it's just longer. So it's a little bit harder in that sense. And, it's more hospitalized, medicalized, this or that. Fine. And so let's say people out there, they hear this and they're thinking about what they want to do. And let's say they say, I do want an elective induction at 39 weeks, or I want an induction for risk reducing, whatever. I want to be induced at 39 plus weeks. They go and they talk to their doctor, their midwife about this. What are the things they need to consider with their doctor or midwife other than sort of the stuff we've spoken about? I think this we're getting into sort of like logistics.
Right. Some hospitals are not able, they don't have the capacity for the volume that comes along with this. Again, instead of a patient who has a 24-hour labor, 12 of it is at home, 12 of it's in the hospital. Now you have all 24 plus hours of it in the hospital.
Right.
So not all places are able to accommodate it.
Yeah.
Then there's more of like the specific logistics of, I want a certain day so I could have a certain doctor, or so I can time it on a certain day for whatever reason. And that's not always available either.
Yeah, I think that there's medical care and healthcare and finances are very complicated, and we're not going to solve them on today's podcast. But suffice it to say, most big hospitals in this country do not have the capacity to induce everybody at 39 weeks because you just need more rooms, and it's very hard, and you need more nurses, and there's way more cost associated. Now, it is possible to do a cost analysis and say, oh, no, actually in the long run and the big overall cost, it might be better to induce everybody because you have fewer ultrasounds and fewer prenatal visits and this is fine. But as just a standalone hospital labor floor, it's harder to induce everyone at 39 weeks because, like you said, if people are in the room twice as long, you need twice as many rooms, right? Or half the number of patients. It's just that's how it goes. So that is something that even if you want it, it may not be available to you.
Yeah.
At all, or in a certain day that you want, like you said, because you want to do it on a certain day of the week or a certain doctor or a certain midwife, whatever it might be. I think another thing is it's really important to know, obviously, like we said before going into it, this is going to be a longer labor. That's on your end. But also you have to sort of feel out, is my doctor, is my midwife, is my hospital, are they the type of place that are comfortable with the longer induction? And that was actually one of the, not criticisms, but one of the comments on the ARRIVE trial is, all right, this sort of works in the best case setting, but if you roll this out everywhere, are all the doctors and midwives going to be comfortable? Midwives probably would be, but are all the doctors, they're
Shout
better,
out midwives.
They're better than this and us. But are all the doctors going to be comfortable with these really longer labors, or is everyone going to end up with a C-section at 5 or 6 o'clock in the evening when the evening shift comes? And it's unfortunate, but that's a reality. Yeah. And so you have to sort of, and how does someone sort that out with their doctor? I mean, you can just ask flat out, like, do you guys induce people? Are you comfortable long inductions? Are you the only one there? Or do you have someone who takes over for you at 7 p.m. or whatever it is, so that it's, if there's more of a shift work, then people are less likely to quote unquote care how long a labor goes because whatever. And that's a complicated discussion that you're not always going to be able to get a straight answer out of people. Yeah. And you have to sort of feel it out and just say, like, is this the type of place that seems like they'd be cool with what typically happens in an induction, which is 18 to 24 hours? Or are these is this a practice where, like, I'm going to get section at noon.
Yeah.
And that's it, in which case you may not want the induction because it's not going to give you the outcomes that you're looking for. And that's a really important part of this. Let's say it's the opposite scenario. Let's say someone goes to their doctor, midwife. Again, this is more likely to be a doctor than midwife, who says, in my practice, everyone gets induced at 39 weeks. Because I read the ARRIVE trial and I believe that it's the best outcome for my patients. So I recommend an induction for all my patients at 39 weeks. And let's say you're someone who doesn't want that. That's not your cup of tea, right? What do you do?
Oh my
right?
God, you're giving me the hardball questions here. I wasn't ready for this.
Melka, this is advanced level. You're graduate level podcasting.
I'm having
you're not,
flashbacks to being a resident board sign
This
out.
isn't podcast 101. This is graduate level podcasting. I mean, but I think that is a concern a lot of people have. People have in both directions. Like, I want to be induced and my doctor midwife won't let me, or I don't want to be induced and they're like sort of pushing me into this. So what should people do in that circumstance?
I think they need to just say, I don't want this.
Yeah.
Like, what are the risks of waiting? What are my other options?
Yeah.
And I think in a way, it is hard for doctors because there are people that do believe this is the right thing.
Yeah.
And I think it's fine if a doctor wants to say, I think everyone should deliver at 39 weeks. Like, we do that for a lot of things. For like VBACs, ECVs. Like, we often give our own opinion. Right. I don't think this is different.
Right.
I don't know that we're there yet where you could require this for everybody.
Yeah, I think for people, it is important to just double check. I think the first question I would ask if I were the patient in that circumstance, or my wife or whatever it is.
Say like, what if I don't want to?
Right. That's a second question I would ask. The first question I would say is, I just want to be clear. Are you recommending I'm getting induced only because I'm 39 weeks, or is it that plus something else, right? And they say, well, no, I don't do it for everyone, but anyone who's over 35 and had IVF and has this and has this and has this and is 39 weeks, I recommend delivery. That's a very different answer than no. Everybody, across the board, if you're 39 weeks, that's what I recommend. And the only reason I'm recommending it for you is that 39 weeks. So if that's the answer to you, then I think it's fair to sort of push back a little bit and say, okay, like, I hear you, thank you. What if that's not what I would like? And, I recognize that's what you think is better, but are you okay? Are you comfortable with me maybe pushing back? And you can, again, I think most, even doctors who are very dogmatic, if someone responds to them, kindly, respectfully says, listen, I hear you, I respect you. Would it be okay if I pushed back on that a little bit and said, like, what if I didn't want that? And I understand why you recommend it, but what if I wanted to wait till I was 40 weeks or 41 weeks? Would you be okay with that? What would you do in that circumstance? How would you monitor me? I think that's going to get you a lot farther with that provider than sort of like, hell no, right? And that type of thing. And
I mean, we see that even with medical indications.
Yeah.
Somebody with high blood pressure, diabetes, that we tell them our recommendation, standard of care, whatever it is. And they'll say, well, what if I don't want that? And then it's a much bigger discussion in terms of what the risk is, what the benefit is.
How bad is it for you? How much of this just sort of like protocol versus really? And I think that it's important to try to distinguish how much of this is unique to me, my circumstance, my medical issue, my cervix, my baby, like all of the things that are unique to me versus across the board recommendation. And that's a great way to get a sense of what is the reason they're recommending it. Because it may not just be because you're 30. And they may say, oh, no. If you were A, B, and C, I would have you go till 40 or 41 weeks. But since you're D, E, and F, here's why I think it's better. And I think that that's a really important component of it. Plus, it's also, if it's very meaningful to you, ask early in your prenatal care. Hey, in your practice, how do you handle the end of pregnancy? Do you recommend everyone do this, everyone do that? And if they have a standard policy, let's call it, you may want to push back early in pregnancy, and then maybe it's not the right place for you. And that's okay, but that's usually a better conversation to have at 9 weeks than at 39 weeks if you feel very differently from them. Now I'm going to ask you to predict the future.
Oh, great.
What do you think is going to happen with this moving forward next 5 to 10 years? Is it going to become more common, less common, stay about the same?
I think it's going to become a little more common. I think we're going to see a shortening of the window of induction. For example, like as of now, somebody who's young, like under 35, no medical problems, all our professional societies will say deliver by 42 weeks.
Right.
Like 42 weeks is post-term.
Right.
It's not common we get someone going that far, but I think that's going to start changing.
Right.
Because like I do think late 41 weeks, you are starting to see some of those risks increase.
Yeah.
So I think that's going to change. You know, maybe now instead of AMA being 39 to 41, it'll be 39 to 40.
Right. AMA is advanced maternal age, 35 or over.
Well, they've already listened to our AMA podcast, so I bet all our listeners know that already.
It's true. Unless they mean against medical advice, which someone filled out on the pit. Someone else had to fill out an against medical advice form. Yeah, an AMA
I'm
form.
not watching
I like that. Yeah, okay. I'm binging it. It's pretty good, actually. It's like ER. They're just redoing all the hits,
nice.
30 years later. But,
I heard they're rebooting Scrubs. They really are bringing back all the hits.
It's all good. Yeah, I think.
Yeah, that's what I think. I don't know that things will ever become so medicalized that we will all recommend it.
Yeah.
Because I think that's going to then lead to people moving away from hospital deliveries and towards places that may not be as well regulated or may not be as safe.
Yeah, I think, I don't, obviously none of us know the future. I think that people, both patients and doctors, are going to want this a little bit more as time goes on. Not everyone, but I think that number is going to go up. And I think that we're probably not going to solve healthcare and, finances for healthcare dollars in the next 5 to 10 years. But I do think that probably places are going to come up with ways to sort of allow for induction, but maybe not use up resources. So for example, people are toying around with doing some of the induction process at home, or maybe having a different part of the hospital where you're not in a labor room getting induced, but maybe you're in like one of these rooms that has 4 beds in a room and you're there for 6 hours, sort of the induction, just to try to find a way to maybe maximize, space and resources, yet still do a lot of this stuff. And maybe the preamble part do in a different way. And then when you're actually in labor, you go into a labor room. And there's ways to be creative with this. It just takes time to sort that all out, to make sure it's safe, to make sure it's doable, to make sure, all these things in every system. I think that's probably somewhat where we're headed. But right now, my conversations haven't changed. If someone wants to be induced, I think it's reasonable. Logistics obviously come into play. And if they don't, if nothing's, I usually tell people they have a 2-week window, 39 to 41 weeks for almost everybody. Some people need to be earlier. A few people can go later. But basically, the bulk of people, that's where they fall. And I say, if you want to be more on the earlier end, we'll try to make it happen. If you want to be more on the later end, we'll monitor you closely and try to make it happen. And I think I found that's probably the best way to go. Just leave it to the people.
Yes.
All right, Melka, thanks for joining me.
Happy to be here.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.